kind introduction, and it's really a pleasure to be here. And thank you guys for staying around. It's Friday afternoon. It was the same thing when we presented the data actually at the stroke conference. It was also Friday afternoon. So Niraj wanted me to talk about this. We presented it. The manuscript was just published a couple of weeks ago, so some of you may know the results. But I wanted to take a deeper dive into the results and kind of see what you think. So these are my disclosures, but I have to admit the biggest disclosure is that it's a challenge to speak after Stefan. What a wonderful speaker, very energetic, difficult to beat. And particularly when we're talking about hemorrhage, which we have to give him credit, I think really research in ICH was really started and people got interested in it because of Stefan's work with factor 7. So when we talk about research in ICH, we know that there are different targets that we go after. And for a while, and rightfully so, it was going after the hematoma and its expansion. And this started with hemostatic therapy and factor 7, moved on to the blood pressure lowering with the premise that it would limit hematoma expansion. And now there's some interest in reversal of coagulopathy. But there have been also increased interest in the toxic effects of the blood itself. And we have learned a lot over the last few years that the blood degradation products are toxic to the brain and they contribute to brain injury after intracerebral hemorrhage. And people have gone on this in two different ways. One of them is similar to the concept of the MISTY-3 trial, which is trying to go with minimally evacuation of the blood. Unfortunately, MISTY-3, the results did not really come as many of us would have hoped. We went around this at the same time trying to do it in a medical way, and that's by targeting iron toxicity after intracerebral hemorrhage. So let me give you a little bit of a background why iron. So animal studies have clearly shown that after intracerebral hemorrhage, there is a rise of iron in the brain around the hematoma. And this iron comes from hemoglobin degradation that happens after the hemorrhage. The iron is toxic to the brain because it enters into a series of chemical reactions leading to oxidative stress and cell death through a variety of mechanisms, ferroptosis, apoptosis, and autophagy. In animal studies, also deferoxamine, which is an iron chelator, there have been lots of data to suggest that treating the animals with deferoxamine, and when you can see some of the slides there, I don't know if you can see it or not. Where is the pointer here? Which one? This one? Oops. No, we're completely gone. Here we go. Okay, well, yeah, I'm not going to risk it. But anyway, treatment with deferoxamine, what we see it would do to this is that it reduces actually the cells, the ferritin positive cells around the hematoma. It reduces death, neuronal death around the hematoma. And when you do behavioral testing in animals, it improves outcomes. So it's like the wonderful drug in animal models. And this has been shown in rats and it has been shown in pigs. So many years ago, we wanted to see if we can actually translate this from the animal models into the humans. And we started with several studies, phase 1 and phase 2. And phase 2, as I will explain in a few minutes, we had high def and IDEF, and that's what I'm going to talk about today. So for those of you that don't know what deferoxamine is, it's an iron chelator. What it does, it binds to iron, and by doing so, it prevents iron from entering into these chemical reactions that lead to cell death. But deferoxamine also has other protective effects to the brain. Probably the most important one is that it induces the transcription of heme oxygenase 1. This is the enzyme that's responsible for the degradation of hemoglobin degradation products. It has anti-inflammatory effects, and surprisingly enough, it also has blood pressure lowering effects if you believe that lowering blood pressure in hemorrhage is helpful. It's a generic drug. It's been around since 1960s, so it's very cheap, and we know a lot about its safety profile. So many years ago, we wanted to just ask the simple question, can we use deferoxamine in hemorrhage patients? Is it feasible to use it? Is it safe to use it? And how much of the drug can we give to these patients that are elderly and sick and have many other comorbidities. So we started with the DFO and ICH trial, and basically what we did, we treated patients with very small dose and gradually escalate the dose using something called continuous reassessment method. And what you can see here is that we were able to go all the way up from 7 milligram per kilogram per day. We were given this as intravenous infusion for 3 days. And we kept escalating the dose until we reached all the way up to 62 milligram per kilogram. And we stopped there, and we thought that this was the maximum tolerated dose. The reason we stopped is not because we saw any toxicity or side effects from the drug. We stopped because the package insert and the FDA do not allow you to give more than 6,000 milligrams per day. And our patients tend to be overweight, and we were starting to hit this target. So now we figured out it's feasible to do it, it's safe to do it, we know how much we can give. The next question was, what is really the optimal dose? So at the same time, the animal data that looked at the right dose of deferoxamine in animal models suggested that there are 2 doses that were effective. And the human equivalent dose of these was 16 milligram and 32 milligram. So a lot lower than the 62 that we were able to give to the patients. Also in animal models, the question came, what's the duration? What's the best duration to get the maximal effect from therapy? And in animal models, anything over 2 days seemed to be better than giving placebo. But the optimal effect was if you treat the animals for 7 days. So then we came kind of at a tough decision what to do. We know that we can give up to 62 milligram, but we know that the animal data suggests that lower doses are effective. We treated for 3 days, but the animal model suggests that you can treat for 7 days. So do we go with 62? Do we go with 32? Do we go with 16? Do we treat for 3 days or 7 days? So the initial thought is that we wanted to do a dose selection study and a duration selection study. And that was how we submitted the initial grant. We got a quick response from the study section that this doesn't make a lot of sense because 62, you were able to give it to people. There's always this thought that more is better. So you go with the 62 milligram and you have 7 days, go with 7 days. Even though 7 days, you're really biased because you select only the severely injured patients. You exclude a lot of patients. And after some bargaining, we agreed on 62 milligram and 5 days as a happy medium. And we started HIDEF, which stands for high dose deferoxamine in intracerebral hemorrhage patients. And the question that we really wanted to ask was very simple. Is there sufficient evidence to say that deferoxamine does something to allow us to go to a phase 3 trial before we spend a lot of money on a phase 3 trial? So this was a multi-center trial sponsored by the NIH and was 40 sites, most of them in the US and few sites were in Canada. Our main objective, we wanted to see if it's worth it to move deferoxamine into a phase 3 trial. And we wanted to look into this by looking at the outcome or the proportion of patients who have good outcome after 3 months. And we define good outcome as modified ranking 0 to 2, compare it between deferoxamine arm and the placebo arm. And at the same time, because we didn't really treat anyone before for 5 days, because our phase 1 was 3 days, we wanted to look at the safety of this. And quickly, we were lost in translation. So what happened is that we had to stop enrollment after 42 days, 42 patients. And the reason for this is that we started to see cases of acute respiratory distress syndrome piling up. We had 7 patients that had acute respiratory distress syndrome. And the reason why we got nervous about it is this paper on the right side of the screen. This is from the early 1990s in patients who were treated with high-dose deferoxamine for a longer period of time. And these were not hemorrhage patients. These were young patients, mostly have thalassemia. And they developed ARDS. So when we unblinded our patients, it turns out that 6 of the 7 cases were in the deferoxamine arm. So obviously the drug has some lung toxicity that we did not discover in animal models we did not identify this in phase 1. So we had to go back and revise the protocol. So we did the natural kind of dose selection, duration selection study. We reduced the dose back to 32. We reduced the duration of treatment from 5 days to 3 days because the median time to onset of ARDS in these 42 subjects was around 79 hours. And then we revised our inclusion-exclusion criteria to exclude patients who are at high risk of ARDS. At the time of doing this, the data from MISTY, phase 2 MISTY, were coming out, where Dan Hanley clearly showed that hemorrhage patients continue to improve over time. And even after a year, there are some patients that continue to improve. So we decided to extend our follow-up period from 90 days to 6 months. So it was basically the same study, but now it's IDEF, which stands for intermediate dose deferoxamine, but the same objectives. As I mentioned before, our primary outcome was modified ranking 0 to 2, but we also wanted to look at modified ranking at 0 to 3. We wanted to look at the ordinal distribution across the entire MRS score, and we wanted to look at these analyses at 6 months. Now, this is the design of the study. It's multi-center, double-blind, placebo-controlled, randomized study. 294 patients randomized 1-to-1. Half of them would get placebo and half of them will get deferoxamine. We start the treatment within 24 hours, and we wanted half the patients to be treated within 12 hours and the other half between 12 and 24 hours. The reason for this is that in animal model, there was some suggestion that maybe if you start treatment early, you'll see a better response. And then in order to balance the groups, we decided to randomize the patient based on ICH score, based on their NIH stroke scale when they come in, and the hemorrhage volume, and whether they were on anticoagulation, particularly warfarin or not. These are our main inclusion-exclusion criteria. I'll quickly go through them. Basically, anyone older than 80 was excluded. We wanted to make sure that they have some deficits, so the NIH stroke scale had to be greater than 6. GCS score had to be greater than 6. And then the exclusion criteria is kind of what you see in any other hemorrhage trial. Basically, if they have a secondary hemorrhage, if they were really in bad shape when they came in, if they had coagulopathy. So the only patients with coagulopathy that we included were patients on Coumadin if the INR was less than 1.3. Anyone else was excluded from the trial. Then on the right side of the screen, you see what we added. So these are the exclusion criteria that we added to exclude patients at high risk for acute respiratory distress syndrome. And what we used here is the lung injury prediction score. Basically, we adapted it in order to exclude these patients with hemorrhage who we think might be at high risk for ARDS. Now, this is basically the study design. Patients come in, they're screened. Unlike any other hemorrhage trial, chest X-ray became an important part of our screening process. And then they get randomized, and then we treat them for 3 days. We decided to get imaging after this to look at what happens to the hemorrhage, what happens to the edema. And then we followed them up at 30 days, 60 days, 90 days, and 180 days to look at their outcomes. So I want to talk a little bit about the study design because it was different. So what we used is something called futility analysis, and I'm going to explain what this means. So basically at the end, what we wanted to do is compare the outcome of patients in the deferoxamine arm versus those in the placebo arm. And our hypothesis was that if the difference is less than 12% in favor of deferoxamine, then it's not worth it to move forward. Now, that sounds very ambitious, 12% for modified ranking 0 to 2 in hemorrhage patients. That sounds crazy. How did we come up with that? There were no really positive phase 3 trial for hemorrhage to know what effect size to go under. In my view, the only positive trial we have had for hemorrhage so far is really the phase 2 factor 7 trial. And in this trial, the difference 0 to 2 between the treated arm and the control arm was 12%. So that's where the 12% came in. We also so that usually when you see an effect in a small phase 2 trial, when you move to phase 3, the effect usually tends to drop. So 12% in this trial would be around 10 or maybe 9% in a phase 3 trial. And that's why we decided to go with the 12%. Now, the 12% was not based on an absolute difference. Because of the futility design, what it means is that your confidence interval will have to include the 12%. So basically, what we wanted to see is that there is just a hint that the drug can make it up to this level of an effect size. So that's how the 12% came up. Now, for the modified ranking 0 to 3, we made it 13%. And how did we come up with the 13%? That was mostly dictated by sample size and power. This is what our sample size allowed us to look at with sufficient power, so we made it 13%. So what's the difference between the futility design and the regular design? So futility design really is a design that's mostly used in cancer trials. So it's sort of new and not commonly used in stroke or hemorrhage. So in cancer trial, they have lots of drugs. They don't want to do a phase 3 trial for every drug. So they wanted a way to weed out these drugs that look like from the beginning they're not going to work very well. So unlike the usual trials we're used to when we compare two drugs, where our hypothesis that the two drugs are equal, this is the null hypothesis. And if you see significant difference, you say, okay, now we see a difference. The futility design is really different because you start by saying that the intervention is better than placebo. Not only this, but the intervention is better than placebo by a certain percentage, by a certain threshold that you decide what the threshold is. Of course, the lower the threshold, the larger the sample size. So why is this important? Because the futility design really, even if you find that it's worth it to move forward to a phase 3, it doesn't allow you to conclusively say that the drug is better than placebo. So there's still equipoise. We don't know. And because the hypotheses are very different, the interpretation of type 1 error, which is a problem always with multiple testing, is very different. In the usual trials we're used to, when you do multiple testing, people are concerned that you can say that a drug is effective while in fact it's not effective. And the futility design is actually the opposite. You can say that the drug is not futile, but it actually may not be. Oh, I'm sorry, you can say that the drug is futile, but it may not be. So keep this in mind. Now we'll come to the results. These are our baseline data, and I'm not sure how well you can see it, but largely the two groups were equivalent except in few things. And unfortunately, some of these few things may matter. So the placebo group were a little bit older than the deferoxamine arm. The big difference really was in the location of the hemorrhage. So it turns out that the placebo group had around 10% patients higher where they had thalamic hemorrhage, and as a result, they had more intraventricular hemorrhage. So we know that both thalamic hemorrhages and intraventricular hemorrhages are big predictors of poor outcome or associated with outcome. These are the post-treatment characteristics where you look at who got surgery, who got an EVD, who was intubated. We didn't really see a big difference between the groups. And when you look at the effect of treatment on hematoma expansion, edema expansion, changes in intraventricular hemorrhage volume, we also didn't see much difference. These are the safety outcome data. We didn't see any difference. So actually the frequency of serious adverse events with the deferoxamine was less than in the placebo arm. And most importantly, we didn't see a difference in the respiratory problems or ARDS. I think we don't need this. These are the detailed serious adverse events. This is the mortality. Overall, it was low in the trial at 90 days, very similar between deferoxamine and placebo at 180 days, also very low. Now, this is the primary outcome. So this is the modified Rankin 0 to 2 at 90 days. 34% of patients in the deferoxamine arm had modified Rankin 0 to 2. Almost 33% in the placebo arm had modified Rankin 0 to 2. So there was really no difference in the primary outcome. And we can be 100% certain if we do a phase 3 trial using this as the primary endpoint, we're not going to see an effect from the drug. But our secondary analyses are a lot more interesting. So here you can see modified Rankin 0 to 3 at 90 days. And what you see here is that in the deferoxamine arm, the percentage or the proportion of patients that achieved modified Rankin 0 to 3 were 6.2% higher than in the placebo arm. And if you look at the upper bound of the confidence interval, I told you we wanted to reach 13%, and this is just an arbitrary number. We came very close. This was 12.1. So this is at 90 days for modified Rankin 0 to 3. Now you move down here, this is looking at modified Rankin at 6 months, and this is 0 to 2. At 6 months, this is a positive trial. You can see here that almost 9% percentage higher in the deferoxamine arm that achieved modified Rankin 0 to 2 at 6 months. And the upper bound of the confidence interval was 15.6, a lot higher than the 12% than what we wanted. So we had to ask the question, could this be a chance? Is this just kind of a fluke that we see there? So we did a lot of analysis, sensitivity analysis to adjust for everything for this modified Rankin 0 to 2. We used something that Dan Hanley used in MISTY-3, where you adjust for the size of the hemorrhage, the volume of the intraventricular hemorrhage, the location, whether it's thalamic or not. We did it in many different ways, and you see that the results stood out, that still we see a benefit at 6 months. The only thing one that you don't see a benefit is the best worst case scenario, but this is essentially a way that's biased always against the drug. These are the patients that lost the follow-up. We don't have outcome data. And when you don't do this, so in the deferoxamine arm, you always give them the worst case scenario, that they're dead. In the placebo arm, you always give them the best case scenario, which is that modified Rankin is 0. So that's how this works. Now, this is probably the most important slide. And what you see here on the top is the day 90 modified Rankin distribution and the day 180 modified Rankin distribution. Deferoxamine is on top, placebo is on the bottom on every one. What we see here is that the chances of good outcome overall along the entire distribution at day 90 is 10% higher with deferoxamine. At day 180, it's 26% higher with deferoxamine. But what I really want you to pay attention to is not just deferoxamine versus placebo. I want you to compare deferoxamine at 90 days versus deferoxamine at 180 days, and look at the placebo at 90 days versus the placebo at 180 days. What we see here is very interesting, and I don't want to fuss around with the pointer here, but other than the blue and the green, which is people are dead or modified Rankin of 5, everything moves to the left between day 90 and day 180. And because we started with more modified Rankin of 3 in the deferoxamine arm, you can see that by day 180, a lot of them moved to the 0 and 2. And because we had more 4 in the placebo arm at day 90, they moved to the 3 by day 180. So basically, it doesn't matter what patients get. We clearly see that hemorrhage patients continue to improve between day 90 and day 180. So it's the first sign. I think we need to divorce ourselves away from ischemic stroke. I think the 90-day outcome data point for hemorrhagic stroke is really different than ischemic stroke, and probably we should not use it. Now, this is the subgroup analysis. The one on the left side of the screen, this is at 90 days. The one on the right is at 180 days. And what you see here, two interesting things caught my eyes. Although I'm not a big believer in subgroup analysis, but you can see that the drug seems to be more beneficial in women and in African Americans. And I think this is interesting because of the next slides here. So it turns out that there is actually differences in heme oxygenase 1 between men and women. and between African American and non-African American. And we have blood samples, and we're looking into this in our own population. So in summary, what we found is that treatment was safe. It's very cheap. It comes to around $50 a day for the infusion. It's very easy to get. However, if we go by our primary endpoint, it's not going to work. But we have clearly shown that patients continue to improve after 90 days, and maybe 90 days is not really the right time point to look into this. And our secondary analysis at 6 months clearly shows some signal that it could be beneficial, or at least it's not futile to consider reevaluation at this time point. So what have we learned from this? I think that translation is really very difficult. We tried to follow exactly the data from the rats. It didn't really work very well in humans. You have to adjust along the way. It's becoming very obvious that hemorrhage trials will have to be longer and will have to be larger because the effect size is not very big. And the last point, which I didn't really have time to talk about this, there is a lot of interest now because there are a lot of drugs coming to try to target these effects of hemoglobin degradation products, inflammation after intracerebral hemorrhage. And a lot of these trials are trying to use perihematoma edema as your endpoint. And what I show you here is an example of a drug where you can see some effect on outcomes, but you don't see an effect on perihematoma edema. So I think I would be very careful with using this as an endpoint for clinical trials. Another thing that we learned is that try to avoid British journals, because that's where the paper came out. And basically what they do is that they only allow you to only present the primary data in the abstract. So this is only the primary endpoint, and you can't really, all the stuff that I showed you, you cannot put it in the abstract. So a lot of people just look at the abstract and don't read the paper, and you just read the abstract from the beginning. This is a negative trial, we're done. But what I showed you here is that there is really a lot to think about, and there is a lot of data that really challenges what we already know about intracerebral hemorrhage. So I'll leave you with the question that we started, and you make your own judgment. Do we see any hints or any evidence to suggest that this drug is worthwhile moving to a phase 3 trial or not? And I'll leave this up to you. And I just want to acknowledge a lot of people that were involved in this trial. There was a lot of effort and hard work from everyone. And thank you again for the invitation.
Thank you, Madgy. Questions?
Do you have any theory as to how a drug you give for 3 days would have an effect 180 days afterwards?
Why would it work? So I think that's what I was trying to show you from the data between the 90 days and the 180 days. So the drug did something at the 90 days because the 0 to 3, we saw a difference. But I think it takes time for the patients to recover. I think after hemorrhage, you have a lot of edema, you have a lot of intraventricular hemorrhage, you have ICB. So it's kind of jump-started the things, but it was not big enough to see an effect at the 90-day period. And it takes time for this residual effects to kind of resolve to be able to see the difference.
But the drug itself had been cleared and it's not continuing activity.
No, of course, it has been. It's like a jump start, sort of.
So Madgy, what are the next steps for you in terms of deferoxamine?
So we're really struggling with this a little bit. So, of course, the easiest way to say, we're going to go back, do the same thing, but look at 180 days and probably put an early stop to try to replicate the futility early on. And if you see a positive signal, move and complete the trial. If you don't see it, you stop. I'm personally thinking that probably the right way to go about this, it's naive to think that one intervention is going to work very well. And if it works, the effect size is very small, as you can see. So I'm really interested in combination. And I think what we learned from MISTY-3 and from this is that both of them, you can see some effect, but it's not strong enough. And I wonder if combining, trying to evacuate the hematoma to reach to a certain threshold with deferoxamine, I think that probably you might get a bigger effect for the intervention.
Thank you. Thank you, Madgy.
Thank you.